Hello everyone, I'm so glad to see some of you. Some of our volunteers, our founding volunteers at our first event. Makes me super happy. And now I'd like to introduce Mary. She is a licensed clinical social worker who oversees the statewide crisis response system through the Office of Behavioral Health. And prior to that, she's been at the Office of Behavioral Health for 4 years. Prior to that, she's worked for a variety of different direct service organizations in different capacities, addiction medicine, assertive community treatment, and through other ways as well. So help me welcome Mary.
Thank you, Karen, for having me come. Anytime I can talk about crisis services, I love to show up. As Karen said, I've been with this office for about 4 years, and prior to that I was working in the ER at University of Colorado Hospital for almost 10 years doing psych and trauma consult. And prior to that I was in San Francisco for almost 20 years, really providing behavioral health care in all venues, as she said. So I'm going to talk a little bit about crisis services. How many of you guys have heard of Colorado Crisis Services? Okay, that's nice, yay. All right. So the origin of the services, all of us remember that we're here, the Aurora Theater shooting. And at that time, not long after that, Sandy Hook happened. And Governor Hickenlooper decided to really take a look at what we are doing in the state of Colorado around crisis response and crisis intervention. Just a little bit of history. Colorado typically has not allocated a lot of funding for behavioral health care. In fact, coming here from San Francisco, when I used to complain about services there, this felt like a desert to me. Especially working in an emergency department when people came in and clearly needed care. They needed to get into not only detox, but maybe a 30-day program or 6-month program, or they needed to find a psychiatrist. It was really, really challenging. And through my tenure at that job, oftentimes I would think, I have nothing for you. Right? But you do the best you can as a social worker to kind of piecemeal together some sort of a plan. So Colorado, so we were in the lower 48, sometimes 47th or 48th in funding for behavioral health care. And I include major mental illness, psychiatric disorders, as well as substance use disorders. So after the Aurora shooting, and sometimes it feels like something really catastrophic and big has to happen for things to change. And obviously this got the legislature to take a look at, what are we doing here? So of course they convened a commission and they decided that we need to have something that is statewide and streamlined and something that will make care more accessible. So legislation passed, it's now in statute, but it was Senate Bill 13266, basically called Strengthening Colorado's Healthcare or Mental Health System, a plan to safeguard all Coloradans. So the idea was really to have expanded access to behavioral health intervention and mostly crisis. But also the idea of wraparound care and connecting people where they need to go next is a huge thing. I mean, anybody that's a clinician understands we can stabilize a crisis, but if we don't really address the origin or what is going on with that person, they're just gonna keep cycling in the ER, in jail, wherever people show up. So the idea was to expand early access to support and services for individuals, families, promote ongoing recovery, and decrease unnecessary emergency department visits and jail stays. And I just want to talk about that for a minute. Having worked in the ER at University, the gift of that hospital is they had a team 24/7 made up of LCSWs and LPCs that were there to evaluate, figure out a service plan, and either get people where they needed to be or get them home with a safety plan. So most emergency departments or hospitals don't have that kind of service. So University was very lucky to have us on staff, that if someone came in, maybe on a hold by police, or if we had to assess and put somebody on a hold, they had the capacity to do that in a very time-limited way. If any of you have ever been in the ER, they're not places for people with mental health issues or behavioral health issues. They just aren't. They're not going to get the care, even the evaluative process that is oftentimes needed, depending on where that ER is. So what I tell people, we work a lot with law enforcement as well, don't take someone to an ER if they don't have an acute medical issue. Right? Because they're going to sit there for a really long time, especially if they are needing the highest level of care. So locked psychiatric hospital, it can take a really long time to find a bed. And in the meantime, people are sitting in the ER, which is sort of traumatic anyways. right? Because you're exposed to everything else that goes on into an ER. So the idea also around jail. So last year, another Senate bill passed. It's called Senate Bill 207. And there's been some stuff in the media about it regarding sort of supporting law enforcement and law enforcement assisted diversion. And basically, it becomes illegal as of May 1st to have anybody sitting in a jail that does not have charges. And so let me just speak to that. In the Front Range, this is not so much of an issue. And if you think about what the state is made up of, and I always kind of talk about our counties. So we have 64 counties in the state of Colorado. And I would say all but maybe, let's say Boulder to the Springs, so maybe 10 counties. The rest are rural and frontier. And so the 10 counties that have easier access, most of our law enforcement people are not sitting in jails in Denver if they have a mental health issue without charges. But what we have in a lot of our rural areas and frontier areas is there's nowhere to take anyone, right? So they often will sit in jails for days. And it's really, when you look at services available, I'll give you an example. In Custer County, the jail, they don't have anybody to even assess somebody that may even have charges, that are fluidly psychotic. They don't have a pharmacy in town, they don't have an evaluator, they don't have a psychiatrist. So what's going on outside of the metro sort of Front Range area is, I mean, it's really overwhelming. Because law enforcement are not mental health practitioners. They're not meant to be evaluators, they're not meant to be these other things. They need to be free to do law enforcement work. And so the real vision of this legislation was, let's get people where they need to be when they're having a behavioral health crisis, which is not in the ER or jail. So one of the things around these services, and I don't think it's in the next slide, is these services are available to anyone, any age, regardless of your payer source or if you have insurance or not. So if you have Medicaid in Adams County and you are in Summit or you are in El Paso County and you have a crisis, you will get cared for at one of the crisis centers. So it's regardless of catchment area, and I know Medicaid is often driven by that. This system, the great majority of folks that we see do have Medicaid and benefited from the Affordable Care Act and Medicaid expansion that Colorado did. It also is, it's regardless of whether or not you're documented. So the issue with people that are undocumented that are in behavioral health crisis is certainly we can stabilize it, but sometimes connecting people becomes more challenging. So it is really regardless of all that, and it's also self-defined. So I say that because when I show you a little bit of the marketing and even on the website, we don't really define crisis in clinical ways at all. None of the marketing says if you want to kill yourself, if you're anxious. We don't talk about that in clinical ways at all because we want to appeal to people that might have a crisis that they can't name like that. So a lot of it, all people will be seen for whatever self-defined crisis they have. They can call the hotline, they can show up at a walk-in center with whatever. If it's not the right place, the center will get them where they need to be. An example would be if somebody comes in and they've been vomiting blood all day, so obviously this is not the place for them. They need to go to an ER to see if they have a GI or an esophageal bleed or something like that. So they're not medical clinics, so we don't ever say crisis clinics. So when you work with your folks and you decide to give them this as a resource, and maybe there's a walk-in center near where they live, they can show up, but it's not a clinic because clinic is very medical and that's not what these places are. So yeah. From the legislation, these were the key pieces of that. And I'm going to talk a little bit about the hotline because, again, for the great majority of the state, access to a crisis counselor is probably going to be the easiest versus walking in somewhere, and you'll see why, because the majority, there's only 11 walk-in centers in the state, and the great majority, again, are sort of Boulder down to the Springs in this metro area. Part of that is population-driven. When you look at the Front Range, the population of the state, a little over 50% of the population sits in this area, right? Boulder to the Springs. So the hotline. Back in August of 14, the hotline went live. And when they first started, they were answering about 160 calls a day. And so when we see national events, especially because we have access to news 24/7, like it's just constant, right? People get CNN alerts, it's all the time. So when Robin Williams died by suicide, calls spiked to about 350 for a period of 3 days. That was a really clear spike in calls. When there's been celebrities that have overdosed, right? That is also, we've seen a spike in calls. When the Broncos fell out of the playoffs, I believe it was January of 15, that was a crisis for a lot of people, and it's really strange that in January we saw a spike in calls after they lost the playoffs. So the crisis line, let me just explain a little bit about it, because this is what I always encourage people. If you are going to recommend this service, I always say go ahead and give them a call, identify who you are. Say, I'm a therapist, I work here, or I'm a counselor, and just ask them a little bit about the process, because you want to be able to say, this is what happens. So what happens when you call, the phone does not ring. You will immediately get an outgoing message that just says you've reached Colorado Crisis and Support Line, and blah, 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 whatever they say. It's about 14 seconds. Within 4 to 6 seconds, you will get a live person. So when you call the first time to the 844 number, you will never leave a message. These are 24/7 services. They don't all go on retreat together or kumbaya because it's New Year's Eve, right? Somebody is there 24/7, 365. And these are not volunteers. So that's the other piece, just to say these are very well-trained counselors. We have a care triage model right now at the hotline. The call center is here in Denver, actually. So we found initially that all the people answering the phone were master's level clinicians. After about a year and a half, we realized that was not a good use of money, because most of the people calling did not require a master's level or a licensed clinician to answer a hotline. In fact, many hotlines throughout the state or throughout the country are volunteer driven. And I think even in San Francisco, they now have, like, you can text if you're going to jump off the bridge, you can text and you're connected to a volunteer. So the care team model is answered by a bachelor's level or a master's level person. What we find is that the majority of people that are calling by far are calling because of suicidal thinking. Depression, suicidal thinking. The second most common reason, I'm thinking about our November data, is self-injury or self-harming behavior. More women than men call, and that's not going to be surprising. So more women than men are using the hotline. In the age buckets, the great majority of people calling are between, I want to say, I just looked at this before I left, between 25 and 40. So that is the majority of callers. We do collect a lot of data. As you know, the state, because this is out of legislative funds, so we got $23 million the first year. And that sounds like a lot of money. However, when you think about what we're trying to undertake, when many other states that have crisis programs have carved it out, like they've either done a region or maybe they just do a hotline, Colorado decided we can do all this at once. And what we've learned in the years since we've started is that there are still significant gaps in services. Like, it's hard to be all for everyone, right, with $23 million. It's not possible. Just to go back, the other piece that we found is that we cannot hire clinicians. So there are not enough people in the state that want to do not only crisis work, but I think the idea is that a lot of people that do get their master's degree want to do private practice. That whole, like, I want to do private practice. So it takes a very special kind of person that wants to do crisis work. It's not for everyone, and that's clear. They also are not well paid. So as an LCSW for many, many years, you know, you're hiring people out of graduate school, and maybe they can survive on what's being offered to work in crisis services. But when you are older and have a home or a family and other responsibilities, you can't make it. So a lot of people will get their hours and leave and go do their practice, right? So it's been very, very challenging to hire. And the 17 mental health centers in the state are the actual providers of crisis services, and that has created some of its own challenges. But a lot of people, again, will finish graduate school, get their hours at an MHC, which is invaluable. I mean, I think we all have to, I mean, I'm a big proponent of you have to get your feet wet somewhere. It's a really good, I mean, I worked in community mental health, a locked hospital. I mean, you sort of do what you can in the beginning, right? So that's been a huge challenge. The state also has, the last I looked, almost 600 psychiatry positions open. So we don't have enough psychiatrists in this state. So we're starting to look at telehealth. And I'm kind of old school, right? I've been around for a while, and I really believe in, like, being in a room, seeing what they're doing, what they smell like, if they're fidgety. It's really hard sometimes when you're Skyping, there's a delay. But some of our mental health centers and our providers, especially in some of our more rural areas, in the southeast, they have no psychiatrists that physically ever show up. One guy's in Tel Aviv, and he's the child psychiatrist, and one guy's living in California. He's the regular adult psychiatrist. So that's what we're really facing. Those are some huge challenges, is workforce really on all levels. And that, of course, there's another committee that's trying to take a look at that, like what do we need to do to attract people to work in community care? But I get off topic because that's kind of what I do. So the hotline, so the phone doesn't ring, you will immediately get connected to a person. The average call is about 12 minutes or less. So, and I think about 65% of callers to this 844 number have their needs met on the phone, which means there's no need for a rescue. And I don't know if any of you have worked on a hotline, but I've avoided it my entire 30-year career because I have this vision of everything's on fire, right? Everything's on fire. That's not true. I already am so anxiety riddled. Like, imagine answering your phone and thinking, oh my God, there's like a gun thing going on. I've never done it. But there are people that are really they fit into that so well. But the great majority of callers to this number aren't in that kind of crisis. They need to talk to somebody, maybe they need to get connected, or maybe they even just need some sort of follow-up resources, things like that. The hotline maintains, they have a 3,500 provider directory. So there's lots and lots of different providers we don't have individual providers on this. So if somebody calls up and says, I need a therapist, a woman who's in her 40s, whose specialty is PTSD, we do not have private practitioners, but because that is not a consumer-facing service. So if somebody shows up at walk-in, that clinician might say, listen, you don't really need to be in the hospital. You can stay here up to 5 days. This is what we can do for you there. So most of these locations do have the CSU attached to them, but some of them are freestanding walk-in centers. The one on Airport in Boulder is a straight-up walk-in center. The one in Lakewood on 2nd and Union, this one is going to be moving to the Detox further south on Wadsworth. So you're going to have a Detox walk-in center kind of combined. And then the Denver Walk-In Center does not have a CSU. But because they're all, again, these are statewide, if somebody shows up in Denver and needs to go to a CSU, they can go to Aurora, they can go to Littleton, they can go up to Westminster if need be, wherever there's a bed. So again, I don't want to use the word cross-pollinate, but that just came to mind. But it's not like you came here and you have to stay within your area. You get to go to these other facilities. And same with Boulder. So in Boulder County, they frequently send people up to Fort Collins to their crisis stabilization unit. And then in Colorado Springs, they opened up a second walk-in center, and this is on Woodman. They do not have a CSU there, but the one on Parkside does. And again, I think we're mostly metro area, or that's pretty much the volunteers?
Right now, but we also have an active staff member who's been working on the program in Pueblo.
Okay, very cool. So there is a walk-in center in Pueblo and a crisis stabilization unit. It's their acute treatment unit that they're using in crisis services. But that's a good question. So,
approximately how many total beds?
Good question. Okay, so now that always adds. So they are licensed, and this gets deep. So they're licensed for up to 16. Anything over 16, they turn into an institution and there's a conflict. Several of them have 16 bed capacity. The one in Westminster has 12. The one, there's going to be one opening, hopefully soon, next to Bridge House on Santa Fe. They closed it initially, called Santa Fe House. If you're going south on Santa Fe, I want to say it's right past the seminary. They're going to be opening one there. They have 12 beds as well. So I don't want to get into the licensing confusion because it's totally confusing even for us. But usually I would say it's anywhere from 11. The one in Mesa County in Grand Junction has 11 bed capacity.
And then for the state, what's the total?
Of these type of beds, I want to say it's less than 100.
Okay.
Yeah, it's less
Thank
than 100.
you.
Yeah. And they're not at capacity, but yet we're finding when you look at, and I usually have a map, but if you look at where the majority of these places are, again, it's Front Range, right? So again, you're living in Alamosa or in Prowers County, it's not an easy schlep. So crisis stabilization units, somebody can go there on a mental health hold, or they can be voluntary, and the average length of stay is under 5 days, but they can stay 5 days. And I know that in Grand Junction, they often use that facility as sort of a holding area for somebody who needs a higher level of care, like West Springs Hospital is out there. So somebody, if they're not improved enough or stabilized enough, they then frequently will get admitted to the hospital. Okay, so these are the different locations. If you go on the website, it's a pretty cool, easy to use website. So mobile services, so all of the mental health centers prior to starting crisis services did have capacity to do mobile outreach. The great majority of mobile services are done in emergency departments. To me, that is not mobile services. It's just not. So again, the legislation, the spirit of the legislation is we are going to go to wherever the crisis occurs, which means a Dairy Queen parking lot, or my apartment, or the church basement, or whatever, or Boys and Girls Clubs. So the challenge that we've had in the state of Colorado is the culture is people are afraid. There's tremendous fear about responding to a call if they don't know the person or they don't know the neighborhood. And so we really are going to try to challenge that going forward. We're going to re-procure these services. The RFP will be out later this year. We really want mobile services to be truly mobile. And that's what we have found is that it's probably improved a little bit, but we really need to get to where the person is and not tell them, can you get to an ER, can you get here? People in crisis, or if I'm having a crisis, I don't need to get in somebody's car. I'm not going to take my kid in the car. What if he jumps out, right? So again, we want to be more mobilely responsive and have true mobile response. My colleague and I just got back from New Jersey where they did a phenomenal, SAMHSA did a training, and it was mobile response and support services, and it was for under 18, so it was for youth. What an amazing integrated program. Like they get a call and they just go. You know what I mean? They get a call from their screener, there's a 3-way call, and they just go to wherever it is, whether it's an ER, at home, the parking lot, the Dairy Queen, they just go. And we have such a culture of fear here in Colorado about doing that we're going to try to do some training. And how do we prepare our clinicians that when you go to somebody's home that you don't know, how do you stay safe? So we're going to partner with law enforcement because there's some things that can be done. And instead of like, I'm too afraid, we need good supervision, good training, and certainly support around safety is always a primary concern. Obviously in our rural areas, guns are tools. They're not necessarily weapons. So a lot of our counties with ranchers and farmers and just living on the land, guns are just part of their lives. And so we figured out how to ask things in different ways. We're trying to work with the Department of Ag, and I don't know if any of you heard the interview on CPR with Commissioner Brown and Ryan Warner. This was a few months ago. But the current agriculture sort of farm crisis that's happening is similar to the 80s. And I was not here in the 80s, but all that happened back then, right now farming and ranching in the state is coming up to what it was like in the 80s. And we do see a lot of suicide deaths in the ranching and farming community. There's been some work with a documentary film company in Boulder is working with, I think it's North Dakota and Iowa, to really look at how to penetrate these communities. One of the things when we were at the Farm Bureau meeting this year is what we hear in these smaller communities is, even if I feel like I need help, the counselor at the wherever is my son's soccer coach. And it's everybody knows everybody's business. These are really small integrated communities where not only are you the counselor, but maybe you're the assistant volunteer fire chief or you're the whatever. So there's a lot of roles that overlap. There's also a lot of shame. Again, that stigma piece of seeking help. Certainly in this community, it's that mentality of like, we live on the land. We live out here for a reason. Those city folk don't get us. Even when my colleague and I had been out, even in Montrose, there's that real, people want to live out there because they don't like that urban city energy. And so it is, they want the same services that we have here, and that makes it challenging, right? And that's certainly what we hear. But it's also about just pull yourself up by your bootstraps. A lot of that is, I can get through this, I can get through it. So we've partnered with the Department of Agriculture to really look at how do we message this, because it's certainly different than how we've messaged it throughout the rest of the state. And so we have, some of our marketing is black and white. There's a farm, like a barn, and then a windmill, and it just says, the egg crisis is real, the stress is real, let's talk about it. Okay? And so the idea is, at least let's get them calling or texting if they can. The Department of Ag is going to be training the hotline in some ways and connections and how to get support to these farmers and ranchers. It's a problem. Yeah, so we're going to do more of that hopefully this year and try to figure out some of our more isolated communities. So the idea with mobile responsiveness is, if you are in a situation where you don't feel the need to call 911, but you really need some support, and this is probably, you guys are all licensed people, so that's probably not going to be the case. But the idea is that I can call up and say, listen, I'm sitting here with my brother, he's saying he's depressed, he's had a little bit to drink, but not much, I'm happy to sit with him. So urban response time is an hour or less. So this is not imminent danger, imminent crisis, nothing like that. In the rural and frontier areas, it could be up to 2 hours. You throw in weather, you throw in, like multiple calls, it becomes challenging. But that is what the goal is, to try to respond in an hour or less in an urban area and 2 hours or less in more of the rural areas. What I can tell you is that the last sort of data check I did is just over 60% of people that have a mobile clinician come to them do not require a transport somewhere else. We would love that to be higher. If there's a way to stabilize the person, where they are, instead of being like, get in the car, let's get an ambulance, or so that would really be the goal. But again, when we look at location of mobile responsiveness, the majority of mobile response in the state of Colorado is still in emergency departments. And that to me is a really different kind of service. And so we're trying to figure out, how do we make this true mobile response, right? So mobile response providers are master's level or licensed, and if they're not licensed, they have access to a licensed person, usually via phone. And it can be initiated by the hotline. So if somebody calls up and there's a conversation or a dialogue with that counselor, and there's a decision that's made that says, let's get somebody out there, just know that that time frame is big. It can be really big. Not so much in the metro area. Although the metro area traffic can be terrible. It could take it more than an hour to get from one end to another anyways. Any questions about mobile? So this is something that was in the legislation and now it's in statute, and there's really no national models or best practices on what is crisis respite. So everyone kind of does it a little bit different. There's a phenomenal respite program in Sterling, actually, and there's one in Greeley where they use facilities, and they have case managers and clinical involvement. They have a respite program in Boulder where they see a prescriber. So everybody does it a little bit different. We don't have a standard of care, and we don't have any kind of big promising practice that's somewhere to kind of model ourselves after. So we're learning as we go. So respite services would be for somebody that does not need a ton of structure or support. They are safe, they don't meet any criteria for a hold, and they understand kind of what was destabilizing for them. So the ability to at least talk a little bit about what prompted their current crisis. So facility respite is up to 14 days, but also community-based respite, which is provided by peer support specialists as well. So these are trained peer support specialists. Maybe it means I'll meet you at your house, or I'll meet you at the bus stop, and I'll get you to where you need to go next. Again, making sure people are connected to where they need to go. And this varies, availability on this really varies depending on where you live. So we're trying to expand that. What I can tell you is on sort of mid-west slope, certainly on the eastern kind of edge, there's just not enough peer specialists that can do the work. So even if we had tons of funding, it's hard to find peers in some parts of the state. So check out the website and just sort of it gives you a whole bunch of information. There's also, I brought obviously the FAQs and I brought some cards, but if you wanted to print up more of the FAQs, there's a link for providers, frontliners it's called. You can go in there and do that. So this is what some of it, have any of you been down Santa Fe lately?
Yeah.
The new ones are up right now. It says When I Feel Broken. And I think it's sort of southbound on the east side. But this is what the original campaign was. Again, no clinical language. The idea is supposed to just kind of appeal to what are we feeling. And this is end of September, so that is inaccurate, but I can tell you that November date, at least for the hotline, there were 14,000 calls in the month of November. 10,100 were outgoing and are incoming, and a little over 4,000 were outgoing, which means they're doing follow-up. They're checking in. So if I call up for my kid and say, listen, I need to get Max, he's smoking cannabis, I don't want to tell the school, can you help me out? They give me resources. They might say to me, can I call you in a few days, see how that went? Do you need something different? So they're doing a significant amount of outgoing calls to really follow up on somebody in crisis. As of the end of September, it was a little over 564,000 contacts. They're not unique contacts because, as we know, some of our folks live in constant crisis, right? Or wanting to kill themselves and being suicidal is on the front burner. And sometimes we're just trying to make sure it's on the back burner. Doesn't mean somebody's going to leave there not feeling suicidal. It means that that crisis has been managed for the day and it's on the back burner. And that's what a lot of these services are. I can tell you that this funding has not created more housing. People always ask about sort of some of the homeless issues and things like that. It doesn't create more housing. It doesn't give great wages to the counselors that we're trying to hire. It doesn't do any of that. It just creates services. So as I said, we've been in for about 3 years with these services, and we've learned a lot. And boy, do we have, I don't know if I'll be there when it's ever this great functioning thing, because I also want to retire one day, but you know, it's a good start. I guess I would say that it's a good start.